And I have added Sjogren's also today, so that you can go through this pre-test, and we can start the session.
कम पड़ जाता है। बहुत खराब ये आने का मन नहीं ड्यूटी महीने में छुट्टी में छोड़ दूंगी फिर साइकिलिंग मेरा संडे या मंडे से शुरू हुआ मंडे को नहीं अप्रूव कर देगा
बच्चा है जो ढोल तारा ये सब बजा
Dr. Bharath, can we start the session now?
Everyone has finished the pre-test? I'll share my screen. I tried to open in my laptop. I couldn't able to open. I'll start sharing my screen. Okay.
Good
We can
evening.
proceed, right?
Yes, we can proceed. Good evening to each and everyone overhead. I'm thrilled to welcome you all for today's informative webinar on connective tissue disorders. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the evening, Dr. Bharath Sarguru. Dr. Bharath Sarguru is a dedicated family medicine physician with expertise in preventive cardiology, diabetes care, and internal medicine. A graduate at Yerevan State Medical University in Armenia, they completed their DNB in family medicine at District Hospital Ballari, along with advanced training in clinical cardiology and evidence-based diabetes management. With experience across hospital medicine, public health programs, and preventive healthcare initiatives, Dr. Bharath has served in institutions including NIMHANS and Karnataka Brain Health Initiative. Currently, they are working as a consultant in family medicine and preventive cardiology at Prabhu Multispecialty Hospital, Polachi, with a strong focus on compassionate and patient-centered care. Over to you, Dr. Bharath.
Yeah, thank you. Thank you for the wonderful introduction. So today's topic is about connective tissue disorder. So this will be taken in two parts. So first part, I mainly wanted to concentrate on SLE and rheumatoid arthritis. And Sjogren syndrome, little bit of Sjogren syndrome, I'll be touching it. So I'll be sharing my screen. 1 minute. So is it visible?
Yes, doctor, it's visible.
Am I audible?
Yes,
So
you're audible.
the first slide is about what is connective tissues. So connective tissue is that one supports and connects and that separates the tissue. So we will call it as the connective tissue. So major components are cells and extracellular like major components are collagen, elastin, and proteoglycans. And other components like it includes cell and extracellular matrix. So mainly where we can see these connective tissues, it will be present in skin, blood vessel, joint, tendons, cartilage, bone, and internal organs. So we can keep like this. There will be a matchbox which will be holded by the rubber band. We can say that the rubber band has the connective tissue, and the matchbox is kept in a position with the help of the rubber band. So we can imagine like that. So what are the connective tissue disorders? Connective tissue disorders are nothing but the heterogeneous group of disorders that affecting the connective tissues. So what are the things that will affect? It will affect the skin, blood vessel, joint, tendon, cartilage, bone, and internal organs. So it may be autoimmune or inflammatory, or it could be a genetic predisposition. It often involves in the multiple organ systems. So early recognition is important to prevent the organ damage. So moving into the classification, in autoimmune and systemic, we have SLE, systemic sclerosis, Sjogren syndrome, dermatomyositis, and polymyositis, mixed connective tissue disease. In hereditary, we have Marfan syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta. So in autoimmune connective tissue disease, so basic mechanism is like we'll be losing the self-tolerance and autoantibody formation will be there and immune complex activation will happen. After that, inflammation will be there and at the end, tissue and organ damage will start happening. So moving on to the lupus first topic. Lupus is systemic lupus erythematous, SLE, we'll call it as an SLE. So a chronic autoimmune condition marked by widespread of inflammation that targets various organs. It involves the immune system mistakenly producing antibodies that attack the nuclei of the body of own cell. So the term lupus basically derived from the Latin word wolf. reflects the disease potential to cause tissue damage, remission of wolf bite. So what it happens is like there will be a genetic and environment predisposition which will be there. So after once that genetic and environment predisposition happens, there will be an abnormal immune response. So because of that abnormal immune response, there will be an autoantibody immune complex will be formed. So these autoantibodies, what it will happen? It will damage the, it will cause the inflammation and it will damage the organs. Like as I said before, it will damage internal organs, blood vessels, joints, cartilage, and bones. So this is the basic mechanism how that SLE is happening. So the SLE affects approximately in 1 in every 2,000 individuals, and gender disparity, women are mostly affected 10 times more than the men. With the female prevalence is about 1 in 700. So the typical onset is most commonly diagnosed between the ages of 15 to 25. And ethnic variation, high incidence risk in black population compared to white. So that is 1 in 250 versus 1 in 1000. Genetic links associated with HLA-DR3 and often MNS in families. Pathophysiology characterized by immune complex deposit causing the tissue damage. So in SLE, autoantibodies targeting the naive double-stranded DNA and Smith antigens are characteristics markers. This I'll go it later. Just prime to this, and I'll say about what is double-stranded DNA and what is Smith antigen. Okay. Certain medications such as proconamide, hydralazine can induce the lupus-like symptoms mimicking the disease. Presence of lupus erythematous cell is notable diagnostic feature. So in lupus erythematous, what will happen is like the lupus erythematous cell is essentially a neutrophil that has ingested the nucleus of the another neutrophil. So here I will zoom it. So what it will happen is this, like the outer neutrophils are the normal ones, and the center it is like swollen, right? So all the nucleus will form it as a cluster. So it will resemble like a rosette formation, where the multiple neutrophil display in a varying levels of the complement coated proteins. So here in this, with the hematoxylin body, lupus erythematous is ingested by a viable neutrophil. So the nucleus of the neutrophil is pushed to the periphery. So here you can see that arrow mark is pointed. The neutrophils are completely pushed towards the periphery. So it is like looking like a rosette formation. So this is the pathophysiology. The gene which I have said, like HLA-D3 and other genes, interleukin-10, and other environmental factors which includes UV light, the gender and Epstein-Barr virus and other factors. These all will causes the abnormal immune response, and it will start activating the type 3 hypersensitivity immune reaction. So after that immune reaction has happened, so autoantibody immune complex are formed. In this autoantibody immune complex, the complex cascade system will be activated. So in this complex cascade system, you know, like T3A, T5A, so these all will form the membrane attack complex. So these complete complex membrane attack complex factors will be reduced in the acute phase of the SLE. So that is one of the very diagnostic features to differentiate whether this is an acute SLE or that SLE or whether it is an active form of acute SLE or it is an inactive form of the SLE we can diagnose. Like how I'm saying is like initially the autoantibody complex immune complex is formed, right? So in that phase, we'll be seeing the complement cascade system is activated. So C3, C3A, C4A, these all those complement factors will be activated. So in that if that factor is very the level is very low, means it indirectly signifies that acute phase of the SLE has happened. So once the complex system is activated, means the inflammation is going to happen. If the inflammation is going to happen in other as I said, like internal organs or joints or cartilage or bones, then the organ damage will happen. Then it will progress to renal failure, atherosclerosis, pulmonary fibrosis, and stroke, and other forms, other manifestations. It will be happening. So what are the manifestation of SLE? In the oral cavity, they can form the oral and nasal ulcers. In skin, we can see that butterfly rashes and red patches, it will be there. We will be usually saying it as a malar rash or discoid rash. In lungs, we will be seeing the pleuritis, pneumonitis, pulmonary embolism, and pulmonary hemorrhage. In heart, the presentation will be endocarditis, atherosclerosis, and inflammation of the fibrous sac. In the abdomen, some may experience the severe crampy abdomen pain. And regarding the hematology system, it will be like anemia with leukocytosis, it will be there, and lymphocytosis, lymphopenia will be there. So leukocytosis will be there, and lymphopenia will be there, and immature, like RBCs will be like immature, and BP also it will be in the higher side. Usually at the 15 years to 20 to 25 years of age, whenever we are seeing the patient with the lupus, we'll be whenever we are checking the vitals in a multiple vitals calculation, the blood pressure usually remains above 140. So that also signifies that also we should think about the lupus also. That differential diagnosis as lupus. With the skin manifestation, if it is present, usually in the black race, we can't see that butterfly rash or red patches. That is not predominantly visible in black race. In kidney, we can see the hematuria, it will be there, blood in the urine hematuria. And muscles and joints, it will be like severe muscle pain, it will be there. Arthritis patches will be there, and the joints will be swollen. So every features, it will be present similar in the other diseases also, like rheumatoid arthritis also, the joint involvement will be the same. But in SLE and rheumatoid arthritis, how we can differentiate is like the SLE, the joint involvement is less severe. But in the rheumatoid arthritis, the joint involvement is very severe. When we compare the SLE with the Sjogren's, usually in the SLE and Sjogren's, both it will be having the mouth ulcer and oral ulcers. But in the Sjogren's, we will be having the dry eyes, dry skin, some other clinical features. Based upon the clinical features, we can say that the patient has an autoimmune or connective tissue disorder. And based upon the specific clinical features, we can tag them into whether it is an SLE or rheumatoid arthritis or Sjogren's syndrome or other connective tissue disorders. The mucocutaneous clinical features, which includes the malar rash, discoid rash, and photosensitivity rash, and subcutaneous lupus erythematosus, livedo reticularis, alopecia, Raynaud's syndrome, vasculitis ulceration or oral ulceration, nasal septal perforation, and nail fold capillary changes. So in this picture, you can see like malar rash. It will be typically seen in the white race than in the black race. The other point is like renal lupus nephritis. It develops approximately in 50% of the patient. So whenever the patient is developing the SLE, we should be very cautious. One thing is like the flare will be like it will be like pulmonary flare. It will be most common, and second it will be like renal complication will be there, and sudden cardiac death will be there. Mostly the death that is happening in the SLE patient is mostly towards the cardiac death. Approximately 10% of the SLE patients prognosis to dialysis or transplant. Hallmark clinical finding is like proteinuria, it will be there, and progressive renal failure can complicate the assessment of the SLE activity. Nephritis remains an important cause of the disease-related mortality. So how we will diagnose this lupus nephritis is like whenever we are seeing the proteinuria and nephritis like hematuria, it will be there. And indirectly we'll be calculating the complement factor also, which I was saying like C3A and C4A. Whenever they are having proteinuria and hematuria, so and the features of nephrotic syndrome, we can some like GFR is reduced or stage of end stage CKD, we can assess with the complement cascade. The complement cascade is also very low and it signifies towards the lupus nephritis or SLE. So the clinical presentation is usually asymptomatic and gross hematuria will be there, nephrotic syndrome will be there, and acute renal failure, hypertension, and end-stage renal disease. In gastrointestinal and hepatic manifestation, GA manifestation are usually uncommon, which I said previously. Some patients only will be having that abdomen cranky pain, it will be there. Excuse me?
Same combination of the potency of milk and mixed hormones together, they are boiled.
And severe abdominal pain in SLE may indicate the mesenteric vasculitis, resembling medium vessel vasculitis such as polyarthritis nodosa. Diverticulitis may be masked by steroid therapy. Hepatic abnormalities are more often due to therapy or drugs than SLE itself. So whenever whenever the patient with the SLE will comes to us, we'll be doing that ANA profile. All those ANA profile will be negative because from the periphery, everyone they'll think that mixed connective tissue disorder or any other autoimmune disease, the final drug of reserve is like steroids. Once if you start the steroids, the morphology of the disease completely goes out. So we can't able to find out whether it is an autoimmune disorder, like what kind of autoimmune disorder by making out to the INA profile. So whenever the patient comes to you the first time and you see the prescription and someone has started the steroid or like the steroids are not titrated properly, just stop the steroid and give the supportive therapy. Like whenever the patient is having the pain, you just give the pain supportive management and wait for the steroid effect to get washed out. And you check the ANA profile. Then you will be getting the clear-cut diagnosis, or else it will be like all those drugs will be masking out all those autoimmune disease. And hematological manifestation, it is like hemolytic anemia will be there. Hemolytic anemia with reticulocytosis will be there, and leukopenia, that is like WBC will be less than 4,000 on 2 or more occasions. With one test alone, we should not diagnose it as directly to the SLE. And lymphopenia will be there. Lymphocytes, it will be less than 1,500 or 2 or more occasions, same thing. The thrombocytopenia, it will be there. Platelet will be less than 1 lakh. The absence of offending drugs. The offending drugs are like procainamide, hydralazine, which I have discussed earlier. And the neurological manifestation includes behavioral personality changes, depression, cognitive dysfunction, psychosis, may be difficult to distinguish from steroid-induced psychosis or primary psychiatric disease, and seizures. So this is what I'm saying, because whenever we are thinking about, we are not getting any diagnosis or the symptoms are not getting settled, when the patient repeatedly comes to you in the setup, and you'll be thinking that the last drug of reserve is like steroid. So we'll be starting the steroid, or someone will be starting the steroid, and when the patient comes to you, when you look into the other aspect, you could not find anything in the blood investigation. So everything will be masked in the ANA profile. So you have to wait, and you have to treat that the patient is under the steroid-induced psychosis, or that the psychosis is primarily due to any other causes, or the psychosis is due to SLE itself. So we have to differentiate it, and we have to wait for the steroid effect to get washed out. And after that, if you do the ANA profile or if you do the other investigation, the proper diagnosis you will get. Other neurological manifestation like stroke, chorea, and pseudotumor cerebri, and transverse myelitis, and peripheral neuropathy. The ocular manifestation includes conjunctivitis, photophobia, monoocular blindness, that is transient or permanent, blurred vision, cotton wool spots on retina due to the occlusion of the retinal blood vessel, result in the retinal nerve fiber layer ischemia. So these cotton wool spots, all those spots are like, it will happen in every inflammatory disease. So with this thing alone, we can't say it as an SLE. The combined clinical features we should differentiate, like we should mingle together. Okay. And pleuropulmonary manifestation includes pleuritis, pleural effusion, pulmonary infiltrates, and discoid atelectasis, and acute lupus pneumonitis, and pulmonary hemorrhage. And other things like, it will be like resembling like restrictive lung disease and shrunken lung syndrome due to diaphragmatic dysfunction. See, everywhere the connective tissue will be there. So once the connective tissue gets damaged, so everywhere that inflammation is going to happen. So because of that inflammation, the diaphragm won't work properly. Then that it will be that will be presenting as like a shrunken lung. The cardiac manifestation like pericarditis, Liebman sac endocarditis, cardiac failure, cardiac arrhythmia, valvular heart disease, and coronary artery disease. So this is the typical Liebman sac endocarditis. What is Lehmann-Stein's endocarditis? It's like non-infective thrombotic endocarditis involving the mitral valve in the SLE. Nodular vegetation occurs along the line of the valve closure. Vegetation may extend up to the caudate tendon. So these what you will say in the mitral valve, it will be there. Now the caudate tendon, it will be like presented towards the down towards the mitral valve. So from there, the vegetation will extend up to the caudate tendon. So this will be classically seen in the echocardiography. Laboratory finding includes complete blood count. In that, we can see anemia, leukopenia, lymphopenia, and thrombocytopenia. And in urine analysis, hematuria, proteinuria, and granular crash will be there. And inflammatory marker, first of all, ESR will be elevated. Immunological findings includes ANA. ANA is like 95 to 100% sensitivity, but not specific for SLE. ANA will be positive for so many diseases, but it is not specific to SLE. But it is 90 to 100% sensitivity for SLE. And anti-double stranded DNA, it is approximately 60% sensitive, highly specific for SLE. Other important antibodies includes anti-Smith, anti-Rho, anti-La, anti-RNP. Anti-phospholipid antibody, it will be like biologically false positive and positive RPR, it will be there. And lupus anticoagulant, antibody against coagulation factor. It will be increased in the risk of venous thrombosis, arterial thrombosis, miscarriage, and anti-cardiolipin antibodies. So ANA pattern includes like homogeneous ANA and homogeneous nuclear fluorescence. See, like these ANA patterns, how it will be present is like whenever you see in the fluorescent pattern, one pattern it will be like speckled pattern. Speckled pattern, you know, like it will be shattered everywhere. That is one of the speckled pattern. Other one is like homogeneous nuclear fluorescence pattern. Everywhere it will be same. Everywhere it will be same nuclear pattern. So it is tagged as homogeneous nuclear pattern. Differential diagnosis of SLE. So for SLE, you can say every connective tissue disorder because DD in the mixed connective tissues, everywhere you will see the same clinical findings. Only thing is like we should put it into the boxes, and with the help of the laboratory findings, we can confirm that it is what type of mixed connective tissue disorders. So differential diagnosis of SLE includes rheumatoid disease, rheumatoid arthritis, Sjogren's syndrome, systemic sclerosis, dermatomyositis. Overlap syndromes includes mixed connective tissue disorder. Non-rheumatic condition like HIV, endocarditis, viral infection, hematological malignancies, vasculitis, ITP, and other causes of the nephritis. So this is the criteria. If the ANA antibody titer is of more than 1:80, it are equivalently positive. Or if absent, do not classify as an SLE. If it is present, apply an additive criteria. What is that additive criteria is like, do not count on the criteria. There is more likely explanation than SLE. Occurrence of the criteria on at least one occasion is sufficient. SLE classification requires at least one clinical criteria and more than 10 points. So what are the clinical domains that we have? Constitutional domain, hematological domain, neuropsychiatric domain, mucocutaneous domain, serosal domain, and musculoskeletal, renal, antiphospholipid antibodies, complement proteins, SLE specific antibodies. So in these all domains, we'll be having a certain score. If we having the score, it is more than 10 of the score, we can tag it as SLE. So in the constitutional symptoms, whenever we are having fever, and in hematological leukopenia, thrombocytopenia, autoimmune hemolysis, whatever which I have previously explained, we have put it into the criteria. So if the and we have given the some weightage for different weightage for different things. So for example, in renal, if the renal biopsy classifies it as a class 2 or class 5 lupus nephritis, then it is 8. If the biopsy classifies it as class 3 or class 4, then it is highly like we'll be doing the renal biopsy, and if you're getting a lupus nephritis, you can straight away tag it as a lupus SLE, systemic lupus erythematosus. So in that way, we'll put the symptoms and we'll put the diagnosis and we'll put the laboratory investigation and other investigation together, and we'll do the additive criteria. If the criteria comes more than 10, then we can start tag it as a SLE. Moving on to the rheumatoid arthritis, the prevalence is of 1% of the population. Women are affected 2 to 3 times more than men. And keep it one thing in mind, in all those connective tissue disorders, everywhere the women are most affected. Okay. And I'll say the exception at the only one or some are other things. I'll say it at the end. Usual age of onset is like 40 to 50 years. Juvenile forms also occurs. So what are the pathogenesis of rheumatoid arthritis? Like inflammatory cell infiltrates will be there. Synovial proliferation it will be there. HLA-DEW4 association it will be there. What are the clinical features? Synovial tissue involvement which will be present. Symmetric peripheral joint involvement it will be there in hands, feet and wrists. And morning stiffness that is lasting for more than 30 minutes. And subcutaneous rheumatoid nodules it will be there. And inflammatory synovial fluid it will be present. Systemic disease may occur in vasculitis and pulmonary fibrosis. See in that picture, we have the rheumatoid nodule. So whenever see these kind of patient usually we'll encounter in our OPD practice. When middle-aged or like around 30 to 35 to 40 years of male or female, they comes and complains of I am having like distal joint pain or proximal joint pain or morning morning type joint sickness stiffness it is there for more than 30 minutes. Then we should think of rheumatoid. First of all, we'll be doing RA factor. Now that is the thing we have been doing so many days. But RA factor is not only specific for rheumatoid arthritis. So there are some other antibodies that we should do to confirm the rheumatoid arthritis. So based upon the clinical features, symmetrical involvement of proximal interphalangeal joints and metacarpal joints of both hands, wrist, and feet, and morning stiffness for more than 30 minutes, and synovial, some part of the synovial tissues involvement, we can straight away tag it as a rheumatoid arthritis. Here you can see that rheumatoid nodule is there, and clustering of the rheumatoid nodules it is there, and ulcerated rheumatoid nodules and inflamed rheumatoid nodules. Right. That is the inflamed rheumatoid nodule. The rheumatoid arthritis head and neck manifestation, it will be present in the temporal mandibular joint. Usually 55% is symptomatic and 70% incidence on X-rays. And juvenile rheumatoid arthritis, micrognathia will be there. Undersized jaw, also called as the mandibular hypoplasia. In cricoarytenoid joint, most common cause of arthritis involving the laryngeal joints. Approximately 30% of the patient may be having the hoarseness of voice, and 86% of the pathological involvement will be present. Symptoms may include exertional dyspnea, ear pain, and globus sensation. Hoarseness of voice due to rheumatoid nodules and recurrent nerve involvement. And the stridor may require local or systemic steroids, possibly tracheostomy in severe cases. In 2010, rheumatoid arthritis classification criteria. So if it is more than 4, we will be tagging it as a rheumatoid arthritis in this criteria. Involvement of the joints and tender joints, serology, and duration of synovitis, and acute phase reactance. Like involvement of swollen and tender joints. If it is one medium joint, large joint is present, or 2 to 10 medium large joints, or 1 to 3 small joints, 4 to 10 small joints. Here, this when you look into this, here the small joints has more score than the medium and large joints. And if it is more than 10 joints, at least one must be a small joint. So here, whenever the involvement of the joints is concerned, the small joint should be involved in the rheumatoid arthritis. That is the final thing. And serology, neither rheumatic factor or ACPA is positive. One low positive titer on at least one test, one high positive titer on at least one test. And duration of synovitis, it should be less than 6 weeks or 6 weeks or longer. Acute phase reactance, neither CRP or nor ESR abnormal. Abnormal CRP or abnormal ESR, which holds the 1 point. And laboratory finding includes diagnosis primarily based on the clinical grounds. So I'll say that whenever, like for example, at a 35-year-old female comes and complains of morning, whenever I am waking up at morning, I am having like joint stiffness of my hands and like fingers. It is like the morning stiffness is presented for around 45 minutes for more than 45 minutes, and I couldn't able to do any work. Afterwards, some like relaxation is there after I'm moving some joints, but I'm having some of the knee pain is also there. And whenever I'm getting up from the morning, I'm having the severe pain. So in the back of the mind, we should always think about the rheumatoid arthritis. And later, all these criteria we can put into that, and we can come to the final diagnosis. RA factor may become positive approximately 90% by 12 months. So RA associated nuclear antigen and anti-RA 33. These are the laboratory findings. So in this, I have missed the Sjogren syndrome. So I'll directly say what it is. What is the Sjogren syndrome? So it is nothing but a chronic disorder characterized by the immune-mediated destruction of the exocrine gland. So in this Sjogren, we can classify it as a primary and secondary Sjogren syndrome. In primary Sjogren occurs in people with no other rheumatological disease. It will be there. In secondary Sjogren, it usually occurs in the patients those who have the other rheumatological disorders also. Most often, it is oftenly associated with the SLE and rheumatoid arthritis. So in that case only, I told that this SLE and rheumatoid arthritis and this Sjogren's will happen together. So primary Sjogren's, it can happen without any rheumatological disorder, and secondary Sjogren's, it will be associated with the other rheumatological disorder, that is mainly SLE and rheumatoid arthritis. So the primary is the diagnosis of exclusion, and secondary refers towards the SICA complex accompanying any of the connective tissue disease like xerophthalmia, keratoconjunctivitis, and xerostomia with or without salivary gland enlargement. So mainly in Sjogren syndrome, keep one thing in mind: whenever your exocrine glands that are involved, and it is any swelling or any other difficulties we are facing in the exocrine gland, we should indirectly think about a Sjogren's disease. What are the exocrine glands that we need to know? And Sjogren's syndrome, mainly it happens in the 1% of the population and in the 10 to 15% of the rheumatoid arthritis patient. And it is also 9:1 female to male predisposed it will be there. And age of onset, it will be there 40 to 60 years of ages, and associated with the 30 to 40 times increased risk of the lymphoma. That is the B-cell Hodgkin's lymphoma. It has 30 to 40 times increased risk. And Sjogren's syndrome mainly affects the skin, external genitalia, gastrointestinal tract, kidneys, and lungs. Minor salivary glands biopsy demonstrates the lymphocytic infiltration, and parotid biopsy are more sensitive and specific. How we will diagnose the Sjogren's syndrome? There is the diagnostic criteria. If we have any dry eyes or dry mouth, then we can directly tag it. We can directly tag it as a Sjogren's syndrome. We will be doing that Schemmer's test or Rose Bengal score, which is more than 4, and more than 50 mononuclear cells, abnormal salivary scintigraphy or parotid stylography or unstimulated salivary flow, that is less than 1.5 in 15 minutes, and presence of anti-Rho or SSA anti and anti-La and anti-nuclear antibodies are rheumatoid factors. Sjogren's syndrome, 80% experience the xerostomia, difficulty in chewing, dysphagia, taste changes, fissures of tongues and lips, increased dental caries and oral candidiasis, and salivary gland enlargement, and SICA syndrome. It will be there. Sjogren syndrome, the clinical manifestation, it will be like xerophthalmia, it will be there, dry eyes, dry mouth, it will be the predominant factors, and dry vaginal glands, and dry skins, and dry genitalia, and chronic bronchitis, and GI tract and renal tubules, other areas which will be the dryness, it will be present. And diagnosis is like mainly by salivary gland biopsy, and the lab factor includes the rheumatoid factor, ANA, anti-Ro, anti-La antibodies. Head and neck manifestation, 80% of the patient will be having the dryness of the mouth and difficulty chewing and dysphagia, taste changes, everything it will be present. And in other eye complaints, it will be they'll be having the dryness of eye, burning sensation, itching, and foreign body sensation, and keratoconjunctivitis spica it will be there. So these are the clinical features that I have said about the three diseases. One is like systemic lupus erythematosus, and other one is like rheumatoid arthritis and Sjogren syndrome. So I hope you all understand this. In the next part, we'll be seeing about dermatomyositis and other connective tissue disorder. Most probably, we'll be having the class on 27th of August, and in that we'll be discussing about the management part also.
Thank you so much, Dr. Bharath. Can we have the Q&A session? If any participant has any questions, can they put it in the chat box?
Yeah.
If anyone is having any questions regarding the webinar, please put it in the chat box. Dr. Bharath will answer them one by one.
And thing is like we can have that Q&A discussion also. So I hope that you all have gone through the pre-test, and I request you to go to the pre-test back and answer that again now, and we can discuss that questions also. Regarding the treatment part, I'll take in the next session. Okay. So mainly, I just don't want to mix you with this other connective tissue disorder with this SLE and Sjogren and rheumatoid arthritis. These three are the main disease that will be encountering regularly in our OPD practice and also in the hospital setup. So I don't want to miss the clinical features. So I have kept the clinical features diagnosed part of SLE, rheumatoid arthritis, and Sjogren syndrome separately, and other diseases and treatment separately. See, one practical thing I just wanted to say is like whenever the patient is coming with severe pain or unexplained fever or unexplained joint pain or abdomen pain or some reduced urinary output or some other neurological features, always think about the autoimmune disorders and mainly think about the mixed connective tissue disorders. First, you should rule it out. Like basic blood CBC, you should take it, and you should see the parameters. Any anemia is there or not, or reticulocytosis, or leukopenia, lymphopenia, anything is there or not. Then you go for the ESR RA factor. To get the RA factor positive in rheumatoid arthritis, it will take around 1 year. So I won't say you to stick to the RA factor, but if you are seeing clinically, it is and you are thinking that as an rheumatoid arthritis, straight away you go for the scoring, and straight away you start the treatment. See, every disease it will get settled in the steroids, but we need to know the diagnosis, right? So then only we can start the second line of treatment. The steroid will reduces the acute symptoms. Yeah, ANA will be positive in all three. And only the specific antibodies will be, we'll be able to differentiate in the SLE, RA factor, and rheumatoid arthritis and Sjogren's. don't directly start away with the steroids. Okay, the steroids will mask the characteristics of the disease, so which is very tough for the person to go for the diagnosis. So once if you start the steroid, you have to wait for another 1 week or 10 days to uh, until the steroid effect washes out. Then only you can send the ANA profile.
तो ये भी जो है वो बहुत इम्पोर्टेंट है.
So this adalimumab, usually it will cause like drug-induced lupus. Someone has asked about adalimumab. See, everything we can't go for ANA profile, right? It will be costing around 4,500 to 5,000. So some may afford and some may cannot afford. So always stick to the clinical features and always stick to the patient symptoms. And minimally, if you can differentiate, for example, symmetrical involvement of the joints, and based upon the severity, if it is very severe, you can you can minimally tag it as the rheumatoid arthritis, and you can straight away directly start the treatment. And if you are finding that severity is very less, and you are having any other end-stage renal disease or end-stage like ocular manifestations or psychiatric manifestation, think about the lupus. So this is what, like, simple clinical features we can able to find near to the diagnosis, but to the confirmed diagnosis we need an ANA. So that's what I said about SLE, anti double stranded DNA and anti-Smith antibody. It will be specific for SLE, and anti-CCP, it is specific for and with rheumatoid factor positive, it is specific for rheumatoid arthritis, and rheumatoid factor with anti-SCL70, it will be specific for this Sjogren's. These are the specific tests to differentiate them. So that's what we can't specifically order the test. Rather, we can go for ANA profile. Can we go for the that is specific for rheumatoid arthritis, anti-CCP? Can we go for Q&A, question and answer discussion?
Oh, yes, Dr. Bharath, will you be able to share the screen that?
Yeah, definitely I will show. Everyone finished up post test. So regarding the first question, a 22-year-old woman present with the photosensitivity, malar rash, oral ulcer, and non-erosive polyarthritis. Which investigation is the most appropriate initial screening test for SLE? Can someone answer this? You can unmute and answer. Which investigation is the most appropriate initial screening for SLE? So it is an initial screening for initial screening test for SLE. Yeah, it is ANA. 2 has answered. Moving on to the second question. Which antibody is most strongly associated with the lupus nephritis and correlates with the SLE disease activity? I said no, lupus nephritis and correlates with the SLE disease activity. Yeah, anti-double stranded DNA. Moving on to the third question. So other antibodies, like anyone has any idea? Like anti-Ro, anti-CCP, and anti-centromere. So anti-double stranded DNA is most for the diagnosis of lupus nephritis. Anti-Ro, Sjogren's, anti-CCP, rheumatoid arthritis, and anti-centromere is for scleroderma. Yeah, very good. A third question, a patient with the SLE develops proteinuria and hematuria. So they are having lupus nephritis. Which complement abnormality is most suggestive of active disease? So I have said you now, like autoantibody will be formed and that will move into the classic complement cascade. So in that classic complement cascade, all those immune, it will be utilized, like complement cascade, it will be utilized. So we'll be in the active disease, we'll be having the decreased C3A and C4A factors, complement factors. Which of the following is a typical feature of rheumatoid arthritis? So rheumatoid arthritis is a symmetrical involvement. So symmetrical inflammatory polyarthritis involving metacarpal phalangeal and proximal interphalangeal joint is the correct answer. Which antibody has the highest specificity for rheumatoid arthritis? Highest specificity for rheumatoid arthritis. So rheumatoid factor will be there, ANA will be there, but which is highly specific for rheumatoid arthritis?
Anti-CCP antibody.
Yeah, very good. Which is highly specific for rheumatoid arthritis. In rheumatoid factor, when you can expect the rheumatoid factor to get positive in rheumatoid arthritis? Anyone? When you can expect the rheumatoid factor to be positive in rheumatoid arthritis? In how many days or how many years? Yeah, more than 12 months. Correct. Moving on to the other sixth question. A 45-year-old woman has a symmetrical metacarpal phalangeal and proximal interphalangeal joint pain with morning stiffness lasting 2 hours. Which imaging finding is characteristic of established rheumatoid arthritis? So in this joint involvement, initially whenever the connective tissues are involved, initially the inflammatory changes will be erosion. Okay, so it will be marginal erosions will be there. So that is the typical finding which will be seeing in the X-ray that denotes the rheumatoid arthritis. When if it is a symmetrical metacarpal phalangeal and proximal interphalangeal, severe pain and severe morning stiffness more than 20 minutes or 30 minutes, we can straight away directly tag it as a rheumatoid arthritis. So that's what, whenever the patient comes with the metacarpal phalangeal and the proximal interphalangeal swelling, usually we'll be thinking of the bone disorder and we'll be taking the X-ray. Whenever we see that the marginal erosions in that joint, we can think of the rheumatoid arthritis. Here afterwards, when the patient comes with the pain of the metacarpophalangeal and proximal interphalangeal joints, and whenever you are taking the X-ray, in that X-ray you are finding that marginal erosions are present. So directly you should think of rheumatoid arthritis and keep that as a differential diagnosis. A 50-year-old woman complains of persistent dry eyes and dry mouth, and she has recurrent dental caries and bilateral parotid gland enlargement. Which diagnosis most likely? So dry eyes, dry mouth, it will be present in SLE also, and in systemic sclerosis also, and in Sjogren's also. So what is the catchy point is like bilateral parotid gland enlargement it is present. So that signifies exocrine gland involvement that is towards the Sjogren's syndrome. So this is what I said, like put it into the places where the symptoms belong, and only one catchy symptom that you can differentiate with the other connective tissue disorder, mainly with the SLE rheumatoid arthritis and Sjogren's syndrome. So moving on to the 8th question, which autoantibody is most characteristic of Sjogren's syndrome? Whether it is an anti-double stranded DNA or anti-CCP or anti-ERO or anti-SCL70. Yeah, it is anti-ERO. Which important long-term complication is associated with the Sjogren's syndrome? Whether it is an aortic dissection or B-cell non-Hodgkin lymphoma, renal cell carcinoma, or osteosarcoma. Anyone can unmute and answer for this. Which important long-term complication is associated with the Sjogren's syndrome? Anyone? In the chat box? No, it is not a renal. Yeah, very good. It is a lymphoma that is mainly B-cell Hodgkin lymphoma. Okay, about 60% it will be long-term complication of a Sjogren's syndrome. A patient has an inflammatory polyarthritis, dry eye, and dry mouth. Which combination of antibodies would you most strongly support for Sjogren's syndrome associated with the rheumatoid arthritis? So both the Sjogren's syndrome and rheumatoid arthritis. Which is the antibody? You will do.
Anti-CCP plus anti-ROSS.
Yeah, very good. I hope you all understand the basic clinical features and basic diagnosis and basic findings in SLE, rheumatoid arthritis, and Sjogren's. So in the next class, we'll be seeing about the management of these three. Why I have kept the management separately is like the management won't differ in much in this all those conditions. So it will be same like whatever you do, we'll be having some hydrochloric HCQ. It will be there, or some start of steroids will be starting, or some other drugs, second line drugs will be starting. So I wanted to keep that management together for that reason only.
Thank you so much, Dr. Bharath, for this insightful session. I
Yeah,
personally
thank you
found
so
it
much.
on behalf of everyone, I extend our sincere gratitude to Dr. Bharath. Thanks a lot
Thank
for
you,
the
thank you,
session.
thank you so much.
Meanwhile, I have shared the certification form link in the chat box. I request everyone, please fill the form to get your certificates. If you have any further questions or would like more information, please feel free to reach out to us. And don't forget to follow us on social media and WhatsApp channels for updates on future webinars. I have reshared the certificate link in the chat box. Please do fill it.
संबंधित पक्षले 10 दिनभित्र पुनरावलोकन चलाउने अनुरोध गर्न सक्नेछन् भने निर्णय दिएको अपिल गर्ने अधिकार दिएको छ।